Hello to all and a very warm welcome to our webinar today. This is part 2 of the series in collaboration with the SCI Foundation, the Global Schistosomiasis Alliance, the GSA, and the International Society for Neglected Tropical Diseases, looking at delivering on women's health. And it's our pleasure to be with you today to mark and to celebrate International Women's Day 2022, a day that's really there to celebrate women's achievements, but also to galvanize kind of calls to action and those actions themselves for equality, and particularly this year, support this theme of breaking the bias. Hashtag break the bias. It's got its own hashtag this year, and also raising awareness against these inequalities and biases. One of the missions of this year's International Women's Day is really to assist women to be in a position of power, to make informed decisions about their own health. And as a neglected tropical disease community today, this is really the lens that we're going to apply to looking at this momentum. So this is part 2 of a series that has been focusing on female genital schistosomiasis. If you were able to join us last week, we heard all about how these integrations are being rolled out in Cote d'Ivoire with some really invaluable lessons. And this week, we're going to open up and broaden a little bit the discussions and the perspective to really hear a bit more about why this is a matter of urgency to embed female genital schistosomiasis within the umbrella of women's health. And also, what are the barriers or the practicalities that we really need to think about in order to make this happen? When we talk about International Women's Day, inspirational women, I think it's safe to say that one person that really springs to mind this year is Dr. Mwele Malechela, who sadly has left us far too early. Was head of the Department of Control of Neglected Tropical Diseases at the World Health Organization. And we'd like to take this moment to remind everyone that we've dedicated this series to her, and hopefully building on this immense legacy and this vision that she had with equity, with equality right at the core of her work and of what she saw for this sector of neglected tropical diseases and all the stakeholders involved. We really want to take this moment to think about her and her legacy. So a very warm welcome to everyone joining us today for this important discussion and important panel. And very importantly, a really warm welcome to all our panelists who are here today and have joined us and will be here for over the next 90 or so minutes to share their experiences, but also their thoughts and their vision for the future of integrating FGS into women's health, into primary health care and beyond. I'm just going to go around my screen in order of how I'm seeing colleagues tuning in from around the world. We will be hearing from Dr. Bodo Radrianasolo. Hello, Dr. Bodo. You are a doctor of medicine and you're working with the association Kolo Vanona, tuning in from Madagascar. We're also going to hear from Dr. Nanyangwe Siuluta. Hello, Dr. Nanyangwe. Hi, you are General Medical Officer at the Zambart Institute in Zambia, also project manager with the Zipime Weka Schista project. Nice to have you here. Thank you. It's my great pleasure to welcome Dr. Delphine Pedeboy. Delphine, you are Senior Partnerships Manager at Dimaji. Nice to have you here.
Nice to be here. Thanks for having me.
Thank you.
Bienvenue à tous.
Merci à vous. And tuning in from Cote d'Ivoire, if you were with us last week, you'll recognize Dr. Alain Claver Kouamin. Dr. Kouamin, you are a doctor and coordinator of preventive chemotherapy at the National Program Against Neglected Tropical Diseases with Preventive Chemotherapy at the Cote d'Ivoire. Thank you for joining us 2 weeks in a row.
Bonjour Marianne, bonjour à tous.
Bonjour, bonjour. Without any further delay, I'd like to hand over to our panelists to hear all about their experience. This is very much going to be an interactive panel discussion, so by all means, we would like you to post any questions or comments, perhaps your own experiences not just in FGS or working in schistosomiasis, but just more broadly, your thoughts and your experience of women's health, equity, and inclusivity throughout any NTDs. So kind of to set the scene and get us started a little bit thinking about these issues, I'm going to turn to our first panelist, Dr. Kouamin. And for this part, I will swap over to French, but remember, if you do require interpretation, to hit that button at the bottom of the screen. Dr. Kouamin, merci à vous de vous joindre à nous. Et je pense que je vais d'abord me tourner vers vous pour vous poser quelques questions, un petit peu en suivant ce dont vous nous avez parlé la semaine dernière. Simplement pour peut-être rappeler à ceux qui n'étaient pas avec nous lors de la première partie de ce webinaire, quelles sont pour vous les principales difficultés qui sont associées à l'intégration des maladies négligées tropicales dans les systèmes de santé en Côte d'Ivoire?
Alors, merci à vous, Marianne, de me donner l'occasion de présenter un peu les quelques défis et difficultés liés, je peux dire, à la prise en charge des maladies tropicales négligées dans mon pays, ici en Côte d'Ivoire. Mais avant tout propos, je tiens d'abord à dire merci à SCI Foundation qui nous appuie dans la lutte contre la schistosomiase et depuis l'année dernière aussi, qui a aidé à mettre en place une étude pilote à développer concernant la bilharziose génitale féminine. Pour rappel, nous avons 5 maladies tropicales négligées à chimiothérapie préventive pour lesquelles notre programme assure la prise en charge dans le pays. Il y en a plusieurs, mais c'est les 5 maladies tropicales négligées, c'est-à-dire la filariose lymphatique, le trachome, l'onchocercose, les géohelminthiases et enfin la schistosomiase qui nous réunit ici aujourd'hui. Alors, il faut dire que concernant un peu les difficultés liées à l'intégration de la prise en charge je peux dire, de la bilharziose génitale féminine, est vraiment un défi majeur. Hein. Vous le savez, d'abord pour nous-mêmes les agents de santé, vous saviez que la bilharziose génitale féminine n'est pas une affection qui est enseignée dans les manuels de formation de base. C'est-à-dire que tous les médecins ici n'en savent pas davantage parce qu'elle est une maladie inaugurale, je peux dire, pour laquelle on en parle un peu de plus en plus maintenant. Sinon, dans le passé, on n'en savait pas davantage. Donc, l'occasion de cette étude pilote a été pour nous une occasion pour nous informer davantage, d'abord sur la bilharziose génitale féminine. Et il faut dire aussi que la mise en œuvre de cette étude pilote qui a été réalisée dans un des districts de notre pays n'a fait que je peux dire, n'a été implémenté que dans le cadre de cette étude pilote dans 7 centres de santé sur 48 pour le seul district. Je rappelle que la Côte d'Ivoire est divisée en 113 districts sanitaires pour couvrir l'ensemble du territoire et il y a un seul district sanitaire dans lequel l'étude pilote a été développée. Et dans ce seul district sanitaire qui ne regorge que 48 centres de santé, il n'y a eu que 7 centres de santé qui ont été sélectionnés selon le protocole pour mettre en place cette étude pilote. Donc, il n'y a eu que 7 centres de santé avec leurs agents qui ont été d'abord formés à la prise en charge de la bilharziose génitale féminine pour d'abord l'intégrer dans leur service de routine. Donc, ça, c'est d'abord un. Donc, il y a eu d'abord une formation pour ces différents acteurs-là qui ont appris davantage sur la bilharziose génitale féminine. Et ensuite, il était question pour eux de l'intégrer dans les services de routine pour tous ceux des malades qui sont passés dans ces centres de santé pour lesquels ils fréquentaient les services de santé de la reproduction, de prise en charge du VIH, services de consultation de routine pour la population cible. Ils ont donc reçu toute information sur la bilharziose génitale féminine concernant ces patients-là. Ils ont aussi reçu le praziquantel, pour qui je dis encore merci à SCI qui a fourni le praziquantel pour la prise en charge de ces patients-là. Et enfin, on a eu des informations qui ont été notifiées dans les registres de santé pour avoir un peu une gestion des données, une traçabilité un peu sur tout ce qui a été mené comme activité. Donc, dans un premier temps, il y a eu un défi de formation. Donc, il fallait d'abord former les différents acteurs à la prise en charge, à l'intégration de, je peux dire, de la prise en charge des services de BGF dans les centres de santé. Ensuite, dans le cadre de cette prise en charge-là, de cette étude pilote, il y a eu aussi une sensibilisation qu'il fallait faire parce que les patientes devaient être sensibilisées à la BGF dans la communauté à l'effet de fréquenter les centres de santé pour y recevoir l'intégration de ces services-là. Donc, on a eu des agents de santé communautaires qui ont été formés aussi à distiller, à partager l'information aux patients dans les communautés pour les référer vers les centres de santé à l'effet de recevoir l'intégration de ces services-là. Maintenant, dans la mise en œuvre pratique, il a fallu donner maintenant des médicaments aux patients. Et là, ici, c'est vraiment un défi qui était majeur parce que l'étude pilote qui a été mise en place souhaitait, selon le protocole, que les patients prennent des médicaments au cours de la consultation de routine. Alors que vous savez que pour le prendre, le praziquantel, c'est des tout gros comprimés. Il fallait d'abord manger avant de prendre les médicaments. Donc ça fait quand même un peu quelques difficultés parce que le patient vient, il fait une file d'attente d'abord pour recevoir la consultation de routine normale et ensuite, il va recevoir l'intégration des services de BGF qui va leur offrir toute information sur la BGF, leur faire une offre de soins en termes de proposition de prise de praziquantel. Et ensuite, il faut manger, prendre des médicaments. Donc, c'était quand même quelques difficultés là. Donc, pour nous, en termes de difficultés, d'abord, la prise du médicament, ça a été fait, mais ce n'était pas aussi aisé parce que les patients se plaignaient, ça devait prendre beaucoup plus de temps parce qu'il fallait manger tout ça. Il fallait offrir des collations aussi à chaque patient qui devait prendre les médicaments si on voulait vraiment voir un peu quelles aides d'abord consommer la nourriture avant de prendre les médicaments. Donc ça aussi, c'était quelques difficultés. Si jamais on devait l'étendre à échelle, il fallait pouvoir trouver une formule concernant ces collations-là. Donc déjà, en termes de défis, c'était cela. Aussi, le deuxième défi, vous saviez que dans la littérature, on nous dit que la bilharziose génitale féminine se diagnostique avec vraiment des outils de haute performance. Donc, la plupart des centres de santé ici n'ont pas forcément tout ce plateau technique-là pour dépister la bilharziose génitale féminine pour toute patiente qui vient en consultation de routine. Donc, ici, il était donc question dans l'étude pilote de faire une prévention en offrant systématiquement le praziquantel à toutes les femmes cibles de 15 à 49 ans, mais en plus de 15 à 29 ans, pardon, mais qui n'avaient pas de contre-indication, soit si elles n'étaient pas enceintes ou bien n'avaient pas de contre-indication quelconque au praziquantel. Donc, il était un peu difficile pour certaines femmes qui ne se sentaient pas malades de voir qu'on leur propose de façon systématique des comprimés qu'il fallait prendre pour prévenir la maladie. Parce qu'en réalité, la lutte ici, dans le cadre de l'étude, reposait à une prévention en donnant systématiquement le praziquantel bien d'abord en informant le patient en avance. Donc, on a un souci de diagnostic qui n'est pas vraiment faisable un peu partout parce qu'on n'a pas le matériel et ça peut coûter cher, mais il fallait d'abord faire une prévention. Donc, ça aussi, c'est je ne dirais pas des difficultés, mais c'est la réalité du terrain parce qu'on ne pouvait pas dépister l'ensemble des patients qui venaient parce qu'on n'avait pas le plateau technique pour ça. Donc, ici, ça reposait juste dans la prévention en offrant le praziquantel de façon systématique à toutes les femmes cibles, à l'exception des contre-indications. Donc, c'est un peu ce que je peux résumer un peu de quelques difficultés. Maintenant, ensuite, il faut savoir que la Côte d'Ivoire, comme je l'ai dit à l'entrée, a 113 districts sanitaires et l'étude pilote n'a été développée que dans un seul district sanitaire qui comportait, lui, 47 centres de santé, mais ça a été développé que dans 7 centres de santé de ce seul district qui a avec 47. Donc, je pense que comme défi, comme je peux dire lueur d'espoir, on aurait souhaité qu'elle s'étende, qu'elle aille à échelle, juste ne serait-ce que pour juste contribuer à la formation des acteurs de terrain, à l'ensemble des agents de santé, pour qu'ils sachent déjà ce que c'est que la BGF. Et ensuite, ça pourrait les aider, même si on n'a pas encore de praziquantel, à prévenir en donnant juste des conseils, de la sensibilisation à toutes les patients, en attendant d'avoir encore d'autres meilleures opportunités de faire face un peu à cette bilharziose génitale féminine. Voilà, elle est très importante. Surtout, avant de finir, pour dire que, comme on le dit, elle augmente le risque de transmission au VIH de 3 fois et de 4 fois dans toutes les zones endémiques. Donc, vous voyez que quand la prévention n'est pas faite, on en arrive aussi à une autre maladie encore qui est très en baisse dans le pays, mais qui peut faire résurgence à cause de la présence de la bilharziose génitale féminine. Voilà, donc je pense que c'est quelques idées que j'ai pu développer, mais comme je ne suis pas seul, donc je peux rester ouvert à quelques autres questions, éventuellement si je n'ai pas été suffisamment clair dans mes propos. Voilà.
Et c'est tout à fait vraiment essentiel ce sur quoi vous venez de terminer, On estime quand même 56 millions de femmes, rien que sur le continent africain, qui sont à risque ou infectées par la schistosomiase génitale féminine. Et en effet, cette relation avec l'infection, la résurgence du VIH, mais aussi étroitement liée au dépistage de cancer, etc. C'est très, très important. Donc, merci beaucoup, Dr Kouamin, de nous avoir rappelé tout ceci et aussi d'avoir résumé si brièvement et de façon très utile le webinaire de la semaine dernière. Et j'ai posté dans le chat le lien vers l'enregistrement pour tous ceux qui souhaiteraient en savoir un petit peu plus sur ce pilote très important. Vous nous avez bien parlé des problèmes de formation pour les techniciens sur le terrain, mais aussi la sensibilisation des patientes et vraiment les limites, les ressources en fait par rapport au dépistage. Et ça a été très intéressant d'entendre ça de la part de votre perspective en tant que travailleur du secteur médical. Et ce qui serait intéressant, je pense, pour compléter ça, ce serait d'entendre maintenant le témoignage justement de vos patientes, l'une des patientes qui aurait été affectée par la schistosomiase. Et pour ce, je vais repasser à l'anglais.
D'accord.
Voilà. Et I'm swapping back to English to just ask now, invite to share some of your experiences with us, Dr. Delphine Pédebois. You were working for many, many years in several African countries, I believe about a decade in Malawi, also Tanzania, South Africa, and in your role as partnerships manager at Dimaji, you've had the opportunity to travel. And as part of that, you were diagnosed with female genital schistosomiasis. And we were wondering whether, building on a little bit from the insights that Dr. Kouamin gave us, whether you would be able to share with us some of your perspective, but also your experiences of diagnosis and perhaps some of the many challenges we've heard around this disease, ranging from stigma to lack of awareness, whether it be amongst women or amongst healthcare professionals, and just anything that you would be happy to share with us.
Thank you, Marianne. Donc, bienvenue à tous. Welcome, everyone. I'm actually half French, half British, so I'm able to do both. But today I wanted to speak in English because it's easier for me. My whole medical journey was in English, so it's easier for me to speak in English about this topic. So I'll be speaking for about 10 minutes on my experience. And first of all, want to acknowledge that I've been very lucky as a white European who has access to a lot of medical care. But despite that, it's been extremely challenging, and I've had a long-lasting impact on my life, having had FGS. And so I can only imagine what it's like for other patients who maybe don't have access to the same privileges that I have. So I want to just acknowledge that before I begin. So my name is Delphine. As Marianne said, I work in the digital health space. I help community health workers with applications, apps for data collection, especially in the fields of HIV, TB care, reproductive and maternal health, sexual reproductive health, and a lot of other health domains. So we do partner with organizations like Sightsavers who are working on other NTDs, but in my opinion, we don't do enough work in NTD management and support because obviously there isn't much funding and we depend on a lot of the funding cycles. So I spent my whole career living and working in sub-Saharan Africa, where I came after I finished school. I live in Paris now because I'm receiving treatment still, and the medical system in France is very good insofar as it is paid for by the state and taxpayers, obviously. But I can see specialists for free at the tropical health units there, so that's why I've gone back, which is ironic because obviously most of the FGS is in Africa and developing countries. So when I got asked to share about my experience, I was nervous. because it's a highly personal topic, and I never thought I'd be talking about these intimate details of my life in a public seminar, but life is full of surprises. So I also think it's my duty to share. As I said, this topic is close to my heart, and I think it needs more publicity for the millions of women who are still suffering in silence without much hope. So I went on a work trip in Malawi from South Africa in 2017. And when I returned, I had a bout of fever, which was assumed to be malaria, but the malaria test came back negative. I didn't suspect bilharzia, even though I knew much about. I do a lot about it because my coworker had tested negative, and we were working in the same environment. So, you know, as Dr. Kouamin said, it is a problem to take praziquantel when you don't think you have bilharzia or as a preventative, because it's very taxing. You take bilharzia, you take the praziquantel or biltricide, as it's also called. It's quite a heavy drug. So I was advised by other doctors to, or I was advised informally by some of my doctor friends to not bother taking bilharzia. Praziquantel. So my symptoms started a few months later, almost a year later, when the FGS symptoms. I had on the skin, there was sandy patches, what they call sandy patches. There was also intense itching and pain. I also had a urinary problem, which is linked. So I had urinary urgency with all negative tests for bacterial infections. So that wasn't also, you know, it was very mysterious. So I consulted with a gynecologist in Cape Town, South Africa, on March 2018. And there was a lot of difficulty getting diagnosed properly. First of all, the gynecologist never asked once for my travel history, even though I was on the African continent, which I then realized was a very bad medical neglect or omission. The diagnosis was done by elimination. So first they suspected thrush, and then that was not the case. They then suspected bacterial vaginosis. That also wasn't the problem. And then they said it was another STD. They said it was herpes, which I tested for, and the test came back negative. I also want to add that there was a certain amount of, I call it cycle of shame and blame and guilt as well, because in terms of, you know, shame, it's a very obviously shameful thing to talk about in society in general. Even, you know, in a more sort of liberal white community that I'm a part of, it is still a stigma. So I can only imagine what it's like in more traditional, more conservative countries. There was also a certain amount of there was also a certain amount of blame. So I was blamed by the doctor for having had unprotected sex and contracting an STD, which I had not. And I was, my partner was blamed. The doctor said to me, your partner is lying to you about his STD screening, and he definitely has herpes, as do you. This was not true. And so I was blamed by the medical staff for my problem, which I think is absolutely outrageous. And also guilt, because I thought once I did get the diagnosis 4 months later, I felt very guilty, because I thought, well, I work in public health and I didn't even know about this, and I should have known about this. I should have known better. So I was diagnosed by biopsy, which simply means they cut a piece from the private regions. And this biopsy was carried out very poorly and left me with a lot of pain, because the area was already inflamed and painful. So this, you know, affected my personal relationship with my partner at the time. And I had a lot of physical trauma for at least 2 years. So that was very difficult. And at least at the time, I thought, you know, at least I have access to a biopsy, and which is expensive. And I was on private medical care in South Africa. So I was very lucky in that sense. So I was sent to a physician for a full physical exam, which didn't involve any internal examination. It was just, you know, an outwards physical exam. And I took a praziquantel. There was intense pain as the parasites died off. So there's a parasite dying off period. For a few days, I had a lot of pain in the genital area, and it was quite uncomfortable. And I had a second dose 2 weeks later, as you do, to do the second dose. But I threw up as I was vomiting, as my body couldn't take it. I had not had they tell you to eat, and I had not had enough food. So as a doctor, Kouamin said, it is necessary to eat food when you take the praziquantel for sure. But the doctor hasn't explained that to me. So that was a bit strange. I then tested negative 2 months later. So I would say there was a certain amount of trauma, psychological trauma from this, because there was just a feeling like I was alone in the medical process, that no one really knew what was going on, which is always a very stressful thing. And also the fact that, I couldn't find any information online, or very little information, or information that was very worrying, that had been studies that had been carried out on men, on the, urinary bilharzia, on things like bladder cancer that results, and so on. Because you remember, I had bilharzia for quite a long time in my body. It's a year, which is not relatively not long. Some people go 30 years without being diagnosed, but I felt that it has been quite bad for the body. So the next thing is, I want to talk about the damage that it has done to me long term, which is something I wasn't prepared for. So I started experiencing chronic bladder pressure and frequent urination, and I've had this for 4 years now. So it's almost like a cystitis, but it's constant, which is very, very challenging, as you can imagine. And also not finding any information online about this. No formal diagnosis has been made. They've tried many things on me. I've had 4 different urologists, and they don't know what to do. They've put me on many different drugs, even things for prostate illness, which, was experimental. I've been like a guinea pig, medical guinea pig, which has been very, quite stressful. And the biggest thing is also feeling isolated, feeling like I can't talk to anyone, that there aren't any user forums online or patient forums online that would help exchange tips, gain more information about this issue. There was no community, and I couldn't talk to a friend, because I could, but people wouldn't understand about this. So all the doctors have said that the symptoms will pass, the bladder lining will repair itself, and the gynae symptoms have largely left. I do still feel pain from time to time, where the biopsy was done, and also just general pain. It comes and goes. But the biggest problem is the bladder issue, which only really started after I was treated for FGS. So it's a side issue, but I think it's important to mention that these two can go hand in hand. I've also been diagnosed with autoimmune problems since the FGS, and I don't know if there's a relationship between bilharzia or autoimmune problems, but I suspect that there might be, as the immune system obviously goes into overdrive to try and counter the parasites. I'm not sure. I've also been told different information by lots of doctors. So again, contrary viewpoints, so-called specialists that don't really know about it. They've never seen it. And they've only ever seen it with maybe African women who live in Europe or live in South Africa. But if as a white person, they never suspected it, because of course it's, mostly, I mean, I'm one of the few white patients, I guess. So I will share what I want to see, and the message I want to leave you with is that I would like, as Dr. Kouamin also said, I would like FGS to be in all medical curricula around the world. It's a doubly neglected disease, because it's not only an NTD, but it's a women's NTD. So the double neglect is a big problem. I would like there to be maybe a way of using tech to help a community group for women, to help create that. So I work in the tech field, and we have user groups for other, like women with HIV who can join a WhatsApp group or so on. I think that would be helpful to try break the stigma and help women have solidarity amongst each other. And those community groups to be in local languages like Chichewa or whatever a local language that is appropriate. I also think that there should be research into cures for, and not only research into cures, but just general research around the long-lasting chronic effects of FGS, because I feel like that hasn't been done enough. It's almost like you take praziquantel and then you go home. Well, let me tell you that the actual active phase and the active phase of the disease was nothing in comparison to what I've experienced since then in terms of what it's done to my well-being, my mental well-being, and general physical well-being as well. And I just feel a bit helpless, because I feel like, you know, I'm a privileged white European with access to amazing healthcare in my own country, in South Africa, even went to London to seek advice at LSHTM, and I feel like I still have no answers to what I'm going through, and I really feel for the women who are still suffering, those 50 million plus women who don't maybe have access. As I think, well, I mean, I believe that most of these women are in rural communities, and it's they're in contact with infested water and so on. So whilst it's Women's Day, I also I just want to emphasize that it's well and good to celebrate Women's Day, but at the end of the day, the state of affairs is that there isn't sufficient funding for women's diseases, and there isn't enough interest in us in this part of the population. So I do want to make a call to action for that to change. So if anyone knows how to, or if anyone is interested in exploring the chronic aspects of the disease and what happens after you take praziquantel twice, or any other aspect of what I've just spoken about, I would be very happy to talk to you. It's a passion of mine now to make sure that this situation improves, and to be a spokesperson for this. If you need me to testify in your research or provide X-ray scans of or photos for research, I have all of that. So I'm happy to share those documents with you if you want to write papers and so on, if you're in the research community. If you know of anything that can help also on a personal level, if you know anyone else who's been affected in a similar way, I would love to hear, because I would love a friend who I can talk to about this, who's experienced similar. That's it from me. Thank you very much for your time. I really appreciate it. And thank you for all the great work you do. I'm so grateful that there are people like you who are interested in this topic. And I will leave my details in the chat should you wish to contact me. Thank you, everyone. Merci à tous.
Delphine, a massive thank you to you. I think we've found ourselves a global ambassador for FGS. Not only were you just so generous with your very, very personal testimonial, particularly with all the hardships that we're very sorry to hear you had to go through, especially around stigma and so forth, but so many really important and fresh and practical ideas that you've brought to this discussion, particularly looking at this very young demographic that's affected with FGS, women who tend to be really connected. So your idea of kind of digital forums and exploring perhaps that as a support network is wonderful. And we definitely hope to follow up on that. So thank you so much. And please, by all means, everyone do get in touch with Delphine. And on so many levels, your perspective has been really useful. So thank you so much. The thing that really resonated and stuck from your testimonial is really this, what you described as the shame and the stigma, false assumptions, and how other people and even medical staff react to the situation. And perhaps that's something I'd just like to expand on a little bit. While you were speaking, Delphine, we were joined by Professor Margaret Gyapong. Professor Margaret, hello and welcome. Thank you for joining us. I hope you can hear me okay.
Yes, thank you very much.
And we can see you very
Yes.
well.
Thank you. Thank you.
Professor,
Apologies, I had challenges connecting.
no, we would like to apologize. This is meant to be a relaxing and warm experience on International Women's Day, not a technological nightmare, but we've made it. Thank you so much.
Okay.
And
Great.
Professor, you don't need an introduction. I'm sure everyone on this call, I'm very sure knows you really well, but just on the off chance someone is new to this topic, you are professor, but also director of the Institute for Health Research at the University of Health and Allied Sciences in Ghana. You're also working on the FAST project, the FGS Accelerating Scale Together project. You're also part of the FGS Integration Group, or FIG, many of the partners of which are on this call as well. And I'm sure, like many of us, Dr. Gyapong, what you would have heard in Delphine's testimonial is really all these issues around stigma. And I know that's something that's very much close to your heart. And so I wanted to ask you, based on your work and your experience, how could we address this stigma associated with FGS, and kind of opening that up and linking it to International Women's Day from a health equity perspective? Why is integrating FGS in women's health so important?
Okay, thank you very much for the opportunity, and happy Women's Day to all of us. Let me say that let me start with the issue of stigma. I didn't hear much of Delphine's testimony, but I know that she was telling a chilling story from the responses that we are hearing. But when it comes to stigma, from the little that I've done on the FAST package, there's really not one name for FGS. So people describe it as a problem of the gynecological system, and it can mean anything. But critical to FGS is the fact that a woman has reached childbearing age and cannot have children. And in the African context, it's kind of like a taboo. If you are married, the next thing is that you must have children. So if you do not have children, then there's a big issue. You are stigmatized. You are made to feel as if you are not a real woman. And it can send a lot of women into depression because their husbands may go for another wife. The mother-in-law may be asking the husband to divorce her because she is not having children. And the blame is on her and not on the husband. The second thing is that there's a problem of misdiagnosis. So a lot of our health workers, not knowing what the woman is going through, will diagnose her as having a sexually transmitted infection. And you know that comes also with some stigma. She's perceived to be promiscuous. And for young girls, it's even worse because then the health workers label them as bad girls and tell them that they should stop having sex because the problem they have is a sexually transmitted infection. Due to no fault of the young girl, she's being labeled when she does not have what she's being given. And then apart from that, a woman who is always complaining about a gynecological problem is seen to be a bad person. So the issue, people do not see this as FGS as an NTD, but a women's health issue. And I think that's where we need to hit at the advocacy and how to address the issue of stigma. That women have health conditions. FGS is one of them. It is a gynecological problem, but it can be addressed. And people need to know that this woman had this problem, not because she did anything bad, but because she was doing her normal household chores. There's no pipe-borne water. She has to walk miles to the riverside to fetch water, and she gets it through contact with water. So I think our health workers need to be better trained, and that is what we are doing on the FAST package. Our teachers in the schools need to be better educated. On the FAST package, we've done the online training, we've done the face-to-face training, And in Ghana, we have done the subject matter expert training so that they'll be better educated. I mean, at baseline, their knowledge about FGS was next to nothing. They didn't know anything about it. So we should address it from the health system level, from the education, Ministry of Education level, where mass drug administration is used for dealing with schistosomiasis, and also at the community level, making sure that the communities understand what is going on. So following what I've talked about, then we move into the issue of integration. I've mentioned education, Ministry of Education. I've mentioned family health. It means that all the partners should be talking to each other. Currently, you cannot blame us. We have a siloed approach to the delivery of healthcare services, and we must move away from that. We are dealing with a woman who has a gynecological problem. There are family health issues. There's the school health. There's neglected tropical diseases. Everybody has to be talking to each other. Everybody has to understand, especially the gynecologist, when somebody is brought to you with these issues. A simple question about where have you lived? Have you been swimming in river bodies? Have you been fetching water from river bodies? If that question is asked and the response is yes, then we know what is available for treatment. So we really need to be talking to each other. Otherwise, this siloed approach is not going to help. Let me stop for now.
Well, thank you very much. And that's really a huge concept, to really move away a bit from the NTD kind of approach to FGS and really think of it almost purely as a woman's health issue. And you're right, that has the potential to really move things along. And probably at this point, it would be really great to turn to you, Dr. Nanyangwe Siuluta. This is exactly what you've been working on. Just to remind everybody, you are a General Medical Officer at the Zambart Institute in Zambia, but very interestingly, you are Project Manager of Zipime Weka Schista project, yes, which for those who don't know, translates to do self-testing sister, if I'm not wrong. And basically is a project aiming to provide a one-stop home self-sampling for female genital schistosomiasis, HPV, trichomonas, and HIV as a cost-effective, but also a very easy way to circumvent some of the many, many barriers we've heard that women have to face in order to address their own health. So, Dr. Nanyangwe, what we would like to ask you is, based on this experience, what do you see as the future of solutions to detecting FGS, but also to integrating this a bit more seamlessly into sexual and reproductive health screening and other women's health services?
Okay, thank you very much for the introduction. As she rightfully highlighted, I'm the study manager of the Zipime Weka Schista study, with the PI being Amaya and the country PI being Dr. Kouamin. So basically, we firstly conducted a pilot study in Livingston. That is where Amaya did it initially. And then, we thought we could sort of put it on a larger scale, extend it to other sites. So it's basically a longitudinal cohort study that will be conducted over 3 years. And currently we started our recruitment and, we'll follow up in the second year and third year. So we're basically conducting it in 2 sites, one highly endemic area that is in Kafue in Zambia, and another which has a lower endemicity, that is Livingston. Yes. So we just basically wanted to compare the 2 sites. So, so from basically my experience as we've been conducting the study, I feel one of the solutions is creating awareness. Actually, before we started the study, we noticed that not many people know about FGS. Not many medical doctors, as has been highlighted by most of the other panelists, do know about FGS. So it's quite alarming. First we need to sort of educate the healthcare workers. We target the doctors, the nurses, the pharmacists, the lab technicians, like everybody who is providing a health service to somebody needs to know. Because these people who come to us to see us for health services, they entrust us with their health. We can't be, having all sorts of prejudice, as some of the panelists highlighted. So we need to actually know about female genital schistosomiasis as healthcare workers in order for us to be able to do the necessary tests and actually provide the necessary treatment in time before these things, result into complications that are actually going to affect the health of women, at large. And this awareness is not only with the healthcare workers, but also with the people of the community. What we noticed when we started our study was that we needed to engage the gatekeepers, the people that are trusted by the community. We talk of people like the pastors, like the fathers, the people who usually conduct sermons in churches. They'll be able to, reach a lot of people, considering that a lot of Zambians are Christians. They'll be able to educate a lot of people during their sermons and actually be able to reach out to, people who wouldn't be able to reach, as people who conduct studies in specific sites. We also thought of people like the teachers, as has been highlighted. These teachers will go in the schools, they'll educate even the young ones, as well as, the young adolescent girls on the about FGS and the importance of being tested, on it, and also the possible complications of not seeking any treatment, if, have we diagnosed this condition earlier. So there are a lot of influential people that actually need to know about this in order for them to disseminate this information in the communities. So we have actually been engaging what we call the neighborhood health committee members. They actually reside in the community. So whenever our community workers, the people who are working for us, who are actually doing the recruitment, before they go into like a particular block to, target clients for recruitment, this particular NHC actually accompanies them in order for them to be introduced to the people of the community, sort of to, build some form of trust with the people of the community, in order for them to sort of be, welcomed and for them to be able to carry out the recruitment. So there's a lot of awareness that a lot of awareness work that needs to be invested in. And another thing that I think would be a solution would be what we're actually doing. We're doing studies. I feel studies sort of provide evidence. The initial study that was done in Livingston a few years back was able to provide some evidence that, women actually did want to be tested. They found that, it was convenient for them to be tested, at home, and, they would avoid that stigma in the facilities and the like. So this sort of integrated multi-pathogen self-testing that we're doing, as you rightfully highlighted, we're doing self-testing of schisto as well as HPV testing. We're also doing, testing of the urine, testing of HIV. So basically, we're doing these self-tests at home and then comparing the tests at the facilities in order to see if it's more acceptable, if it's feasible, if it's cost effective. And this is also the right approaches that other self-tests took. For example, we have the HIV self-testing that has been integrated into sexual reproductive health. It also took an approach of initially conducting many, many studies that provided evidence for the policymakers. So we basically want to provide evidence through our study to the policymakers in order for them to rightfully integrate this, into the sexual reproductive health services, because this has indeed been neglected. And as most of the panelists highlighted, it's so daunting, amongst the females, as an African woman, I do know, of these complications, that people have and how it affects them mentally. And even issues of mental health, we also need to integrate that as well. Because, as, Delphine highlighted, it's not an easy thing, even in the African society, mental health, people don't really target it, but it is actually a great need. So basically our studies are, how can I say, they are needed. They were needed yesterday, so we actually do need to do a lot of studies in order for us to be able to, rightfully integrate it in the sexual reproductive health system. Another thing is educational sector, as was highlighted by the other workers. We need to, incorporate the education system, as we, as rightfully highlighted. We need to do the mass drug administration in the schools, and as well as educate the adolescents as well, because it is at a tender age that we're able to sort of catch it, hopefully we want to be able to catch it at a tender age before it causes the other complications that actually happen. So I think a multisectoral approach is the rightful solution. So yeah, I think with the experience that we've had so far in the field, yeah, you need to engage a lot of people in order for us to be able to work together. Yeah, thank you.
That's really brilliant. Thank you, Dr. Nanyangwe. And since we've turned to solutions, we're really excited to see where this project will go. And thank you also for highlighting many of the gaps and where the research needs to focus going forward. You mentioned in passing Amaya and Dr. Kouamin, and I'm sure that for many, they also don't need an introduction, but just to remind anyone who's new, Amaya is Professor Amaya Bastindui, Principal Investigator on the Schista project and based at the London School of Hygiene and Tropical Medicine. Dr. Kouamin Shanaube is Site Principal Investigator based in Zambia and with the Zambart Institute. An amazing powerhouse there of a team, and thank you for sharing your findings with us. I believe on the call, we also have Ruth Mwanza, one of your colleagues who was a community health worker working with the Zambart Institute and also the Schista project. Ruth, I know you ran out of battery. These things happen. If you are back on the call, give us a little sign or perhaps in the chat, and then we will hopefully bring you on because we'd love to hear your perspective and your experience from working on this project. Delphine put a really interesting comment, though, that for Delphine, one of the worst aspects was kind of also the mental health consequences. So something definitely to include in the next steps. And Teresa Baird was adding in the chat, I've just lost that, many parallels with the WHO mental health in NTDs research. So perhaps another theme there worth exploring in further detail. On the topic of solutions and turning to the future, at this point, I'd like to turn to Dr. Bodo Radriana-Solo. Dr. Bodo, just as a reminder, you work with the Association Kolo Vanona in Madagascar, and you've been working on a clinical trial for treating FGS. So perhaps to bring together everything that we've heard and addressing some of the gaps here in the treatment of FGS, could you tell us a little bit more about the clinical trial that you're working on, and what findings could you share? What would be the needs and opportunities for integrating any new treatments coming out into healthcare services?
Merci Marianne de m'avoir donné la parole. Bonjour ou bonsoir à tous. Pour commencer, je résume l'essai clinique de traitement par praticante. Nous avons divisé les femmes qui ont participé à l'étude en deux groupes. Le groupe A qui ont reçu le traitement standard de praticante, 40 mg par kilo de poids, une seule dose unique par fois orale. Et pour le groupe B, elles ont reçu 5 doses de praziquantel. Les 3 doses ont reçu le premier jour de l'inclusion à l'essai, séparées de 12 heures, c'est-à-dire s'ils ont reçu le praziquantel à T0. Après, ils ont reçu le praziquantel à T12 et après T24 heures. Et puis, ils ont reçu le praziquantel à la même dose, 40 mg par kilo, à la 5e semaine de suivi. Et aussi 40 mg de praziquantel par kilo à la 10e semaine de suivi. Et nous avons effectué des examens cliniques, y compris l'examen gynécologique, et nous avons aussi effectué des analyses biologiques. Pour le moment, nous n'avons pas encore une conclusion définitive parce qu'on est en train d'analyser les données, mais à titre de résultats intermédiaires, je vais vous partager notre conclusion comme résultat intermédiaire. À la 15e semaine, après le traitement avec le praziquantel, les plaintes comme perte vaginale, douleur pelvienne, douleur pendant le rapport sexuel, etc. Toutes les plaintes ont été diminuées ou disparues totalement. Les types de lésions au niveau du col utérin, comme les grains de sable, que ce soit de type homogène ou de type avec granulation, il n'y a pas de changement après 15 semaines. Mais pour les lésions de type papule d'aspect caoutchouteux, il y a une diminution significative après 15 semaines. Mais le résultat est, comment dirais-je, le résultat c'est identique pour les deux groupes. Il n'y a pas de différence significative entre les deux groupes, c'est-à-dire entre les femmes qui ont reçu les 5 doses de praziquantel et les femmes qui ont reçu juste une dose de praziquantel. L'analyse des données des suivis après 12 mois et après 18 mois est encore en cours. Donc, nous n'avons pas encore pu conclure de quelle fréquence exactement on doit utiliser le praziquantel pour traiter les femmes. Mais d'ici quelques temps, nous aurons le résultat. Mais à titre d'information, nous avons constaté que toutes les femmes qui ont participé à l'essai ont été satisfaites parce que même si les lésions de type grain de sable ne changent pas, ils ont senti qu'il y a une bonne amélioration de leur santé reproductive. Par exemple, il y a quelques femmes, à peu près une dizaine, qui ont été infertiles, mais après prise de praziquantel, ils ont donné naissance aux enfants, à deux enfants. Et ils ont expliqué que au début, ils ont souffert, mais après le traitement, il y a beaucoup de changements. Donc, il y avait quand même une femme qui m'a téléphoné après. Docteur, est-ce que je peux encore prendre le praziquantel? Et je suis étonnée. Pourquoi tu... Donc, pour conclure...
Docteur Baudot, malheureusement, je ne sais pas si c'est seulement de mon côté, mais votre connexion a été interrompue, alors on n'a pas connu la fin de l'histoire. Pourquoi est-ce que cette jeune fille souhaitait...
Oui, c'était... Ok, je recommence. Oui. J'ai demandé à cette femme pourquoi elle veut encore prendre de praziquantel et elle m'a répondu que elle sent que les symptômes recommencent. Comme j'ai dit, c'est après quelques mois de l'essai clinique qu'elle m'a téléphoné. Mais elle connaît que le praziquantel a changé sa santé reproductive pendant l'essai clinique. Vous avez demandé les besoins pour l'intégration de BCF dans les systèmes de santé. À mon avis, on a besoin, peut-être que les autres panélistes ont déjà mentionné, on a besoin de sensibiliser les femmes et les adolescentes. Il faut les informer de l'existence de BCF et les risques et aussi les impacts. Comme tout le monde a dit, les agents de santé ne savent pas l'existence de BCF, donc il faut former les agents de santé, y compris les agents de santé communautaires. Comme besoin aussi, la disponibilité de moyens de diagnostic au niveau des centres de soins. Par exemple, table d'examen, spéculum. Le colposcope est très cher, mais basé sur notre expérience, on peut utiliser une caméra ou un smartphone. Il y a aussi la nécessité en disponibilité de pratiques comme telle au niveau des centres de soins de santé. Les autres opportunités pour intégrer la PGF dans le système de santé, c'est de l'intégrer aux autres programmes de santé, par exemple, le dépistage de cancer du col, les programmes de santé reproductive, les santé maternelle et infantile. Pour terminer ma parole, je remercie le groupe Merck pour d'avoir financé l'essai clinique. Je remercie aussi le ministère de la Santé à tous les niveaux et toutes les autres institutions à l'étranger et les participantes à l'étude. Je vous remercie.
Et puis un grand merci à vous également de nous avoir résumé tous ces progrès très encourageants. Et je vais peut-être repasser à l'anglais maintenant. Just to we've heard a lot over the last sort of hour and a bit, lots of progress, but also lots of areas in which really more attention, more resources are needed, whether it be the mental health aspect all the way to boosting the training of the medical body to even know about FGS and so forth. And so I really wanted to go back to all our panelists, having heard their work, their perspective, their experience on FGS and on advancing the research, the control, the programs, reaching out to the patients and so forth. So you will need extra resources always. And what, in your view right now, would be some of the best partners that could be brought into this ecosystem? Or where can we turn to? Where would you like to see more advocacy or more resources brought into the field of FGS? And perhaps I will go back to our first panelist, Dr. Kouamin, if you're able to give us a little bit of insight on your experience. Je repasse à vous, Dr. Kouamin. Est-ce que vous avez bien entendu la question?
Vous demandez mon expérience, c'est bien cela?
Oui, mais aussi se tournant vers le futur, vous aurez certainement besoin de plus de ressources. Et donc, quelle sorte de partenaire ou quelle sorte de ressources est-ce que vous souhaiteriez voir de plus en plus dans ce secteur?
Alors, dans un premier temps, comme on l'a dit, la schistosomiase est endémique dans les 113 pays qui comptent la Côte d'Ivoire. Ça, c'est déjà un point. Ensuite, donc, c'est dit que si on veut aller à échelle, à minima, c'est d'abord de passer à une formation des acteurs de terrain pour les sensibiliser sur l'existence de la BGF et des mesures de prévention qu'on peut faire en termes de pratiques qu'il faut éviter, je peux dire des pratiques à risque d'exposition. Dans un premier temps, ça pourrait réduire d'abord la survenue de la fréquence de la BGF. Ça, c'est de 1. De 2, en plus de la formation, je pense que nous avons d'autres défis. Peut-être que ce n'est pas le lieu d'en parler ici, mais bon, quand même, on fonde un peu notre lieu d'espoir là-dessus parce qu'au niveau de la Côte d'Ivoire, nous sommes en train de refaire la cartographie de la bilharziose, de la schistosomiase. Donc, si on arrive à le faire selon le nouveau protocole de l'OMS, la cartographie au niveau sous-district peut nous permettre de voir dans tous les districts les zones à haute endémicité ou bien à forte risque d'exposition. Au cas où les ressources pourraient être limitées, on pourrait concentrer nos efforts là à ces endroits dans chaque district au lieu de les étendre dans chaque district. aussi dans le partenariat que nous souhaitons avec HLD et SCI, nous sommes en train de postuler pour des sources de financement pour nous aider même, ne serait-ce que de l'étendre au niveau du district sanitaire qui a déjà subi la première implémentation de l'étude pilote. Je dis que dans ce district sanitaire, on a 47 centres de santé. 47 centres de santé et on a eu que 7 centres de santé qui ont reçu, je peux dire, l'implémentation de l'étude pilote. Même si on ne peut que les étendre simplement pour la formation, ça pourrait aider. Parce que, je le dis, dans ce district sanitaire, la prévalence de la bilharziose est de 40%. Parce que c'est une zone qui est fortement irriguée. Donc, l'utilisation des sources d'eau est monnaie courante se fait de façon très régulière dans ces zones. Donc, ils sont fortement exposés. Voilà. Donc, dans un premier temps, on a déjà l'information de cela, ça peut réduire un peu les facteurs de risque. Et puis, comme Dr Bodo vient de le dire ici, hein, c'est d'avoir au moins un plateau technique minimal de base pour aider peut-être à diagnostiquer les quelques symptômes élémentaires. Les quelques symptômes élémentaires, parce que, comme le dit la coloscopie, n'est pas forcément disponible un peu partout. Mais quand l'agent de santé peut, à défaut d'avoir du praziquantel, s'il peut dépister plus tôt ou bien chercher à avoir déjà des lésions préliminaires, ça peut aider. Dans la mesure, comme on le dit, que les symptômes de la BGF sont des symptômes gynécologiques courants. Donc, souvent, on ne l'attribue pas dans un premier temps à une bilharziose génitale qui est en train d'évoluer sur la forme chronique qui deviendra éventuellement une BGF. Mais donc, si déjà dans un premier temps, on a un plateau technique assez de base qui permet déjà de réduire un peu les erreurs de diagnostic concernant la BGF, on peut aider ces femmes-là déjà à... Maintenant, quand on n'a pas pu et qu'on a du praziquantel aussi disponible, ça aide toujours à réduire la survenue. Voilà, donc, dans un autre, maintenant, en dernière position, c'est de l'intégrer dans le paquet minimum d'activités. C'est ce qu'on dit ici, hein. Dans la pratique courante de la médecine, il faut qu'on puisse l'intégrer. De telle sorte que toute personne qui a une consultation de routine, il ne faut pas oublier qu'on peut parler de BGF. Il ne faut pas oublier qu'on peut parler des moyens de prévention. Ça peut aider, au fait, les femmes à réduire un peu le risque d'infestation et encore moins à la survenue de la maladie.
Merci beaucoup. Et une question de Delphine, pendant que vous parliez, est-ce que la colposcopie est nécessaire pour détecter la BGF?
Oui, elle est nécessaire, mais c'est à un certain niveau. Alors que toutes les femmes qui fréquentent les centres de santé sont des femmes des zones rurales. Donc, les centres de santé ruraux, dans ces localités-là, n'ont pas cette technique-là pour faire le diagnostic. C'est en cela qu'on parle plus de prévention dans la sensibilisation et dans la dispensation du praziquantel. Et puis, il ne fait pas de mal. C'est un déparasitant aussi, donc il aide à prévenir, surtout que la BGF ne se guérit pas. Il n'y a pas de traitement spécifique pour la bilharziose. Donc, dès lors qu'elle est installée chez une patiente, elle ne guérit pas, sauf que la patiente ne peut pas présenter de nouvelles lésions. Elle ne peut pas présenter de nouvelles lésions encore, mais sauf qu'elle ne guérit pas de la BGF. Il n'y a pas un traitement spécifique pour cela. Donc, la coloscopie peut être disponible dans les centres de référence pour des diagnostics avec les gynécologues et autres, ou radiologues, mais tous les centres de santé périphériques que nous avons, dans 90%, n'ont pas ça à leur niveau, dans le plateau technique. Sinon, c'est important pour faire le diagnostic de précision et tout. Mais combien de personnes ont accès à ça? C'est un peu là le problème. Donc, du coup, il faut plutôt porter, je peux dire, les défis vers la sensibilisation. Si on a du praziquantel qui est disponible, qui aide, comme le docteur Bodo aussi vient de le dire, vous avez vu qu'il y a des femmes, même dans l'étude pilote, il y a beaucoup de femmes qui ont témoigné. Hein. On a déjà dans les résultats que nous avons de l'étude pilote, on a eu des entretiens semi-structurés avec des patientes, les agents de santé, mais beaucoup de patientes qui recevaient le praziquantel en consultation de routine sont venus témoigner cela auprès des agents de santé qui leur ont offert ce praziquantel pour dire, mais j'avais des symptômes gynécologiques, mais ça a disparu depuis que j'ai pris le médicament. Alors qu'il n'y avait pas de lien apparent qui disaient qu'elles étaient malades et tout, mais elles ont compris que lorsqu'elles ont reçu seulement que la seule dose d'ailleurs même, vous avez vu que dans son essai clinique, il y a 2 groupes de patients pour lesquels certaines ont reçu jusqu'à 5 doses, mais la seule dose qu'elles ont reçue au cours de l'étude, l'autre patient n'en a pas eu plus d'une dose. mais elles sont venues, pour celles qui avaient des symptômes gynécologiques, sont venues signaler que mais, tous ces symptômes ont disparu. Donc, du coup, il y a vraiment une efficacité prouvée avec le praziquantel pour ces femmes qui éventuellement auraient présenté ces symptômes gynécologiques qui pourraient être liés à la BGF. C'est vrai qu'on n'a pas fait le diagnostic de certitude, mais je pense que là aussi, ce sont des facteurs qu'il faut prendre en compte qui peuvent aider.
Merci beaucoup, Dr Kouamin, et tout cela est très, très utile. Je me tourne maintenant vers Delphine. Delphine, I'll probably swap over back to English. You've given us a lot of insight and really a lot of food for thought in terms of the gaps and just really turning towards the future. What would you like to see more of? I know on the chat there's been a lot of talk. If anyone's not been on the chat yet, please do go ahead to really boosting this awareness at the medical school level. And lots of colleagues also on the chat are really going in the detail of how and who they're achieving this with in their own networks or countries. So Delphine, would there be anything you'd like to add in terms of what you'd like to see more of, or which kind of resources should really be drawn into this problematic?
Yeah, so two things. So merci à Dr Kouamin pour ces témoignages. Je voulais juste partager que moi, ça a été le cas après la première dose de praziquantel. Les symptômes gynécologiques ont disparu dans la quasi-totalité, mais ça s'est transféré vers d'autres symptômes urinaires. Donc, et ça va relier au deuxième point. Sorry, I'm speaking French, Marianne, because I'm trying to be equal. I spoke English before and now I'm speaking French. Je parle en français maintenant pour les francophones. Oui, donc je pense que, en fait, il faut qu'on réfléchisse aussi au lien entre le FGS, donc la bilharziose génitale, et puis le reste, les autres bilharzioses, c'est-à-dire les symptômes urinaires, les symptômes qu'on peut avoir au foie, les symptômes qu'on peut avoir aux autres organes. Parce que si on fait juste, si on parle juste de cette maladie génitale en tant que telle, il y aura peut-être moins d'intérêt parce que c'est tout de suite une maladie féminine. Je pense que si on inclut, ces symptômes dans juste la liste des symptômes de la bilharziose classique, ça va permettre de répandre ces informations plus facilement. Parce que j'ai peur qu'en distinguant, c'est bien de distinguer parce que c'est scientifiquement précis, c'est quand même, c'est important, mais il faut quand même se rappeler que quelqu'un qui a des symptômes aussi de FGS a également peut-être d'autres symptômes. Moi, j'ai ça m'a affecté au niveau des autres organes aussi. Donc, ça ne s'arrête pas aux organes reproductifs. Ça peut aller ailleurs, quoi. Donc, il faut quand même qu'on réfléchisse à ça. Moi, dans ma phase active, j'étais plutôt les symptômes dont on a parlé aujourd'hui. Mais après le traitement, j'ai eu beaucoup de problèmes dans d'autres parties du corps, quoi. Donc, et il faut quand même qu'on fasse le lien entre les deux. Ça, c'est juste une remarque. Je ne sais pas si c'est très utile, ma remarque, mais en tout cas, j'avais envie de faire cette remarque par rapport à mon témoignage et mon expérience personnelle. Après, je pense que, oui, le principal, c'est vraiment d'intégrer ça dans les cursus médicaux, quoi. Parce que, par exemple, même l'OMS, quand j'ai regardé en ligne sur la FGS, il y avait un poster qui avait été distribué aux cliniques un peu partout en Afrique. Et ce poster de l'OMS, il a été fait en 2016. Donc, moi, j'étais diagnostiquée en 2017-2018. Donc, j'ai dit, oulala, mais c'est tout récent, quoi. Quelle chance on a d'avoir le praziquantel et d'être à cette époque-là, parce que je ne peux même pas imaginer ce que c'était avant, quand on ignorait la maladie, quoi, quand on ne savait pas. Donc, la recherche est très importante, mais aussi, je pense, un effort de ne pas forcément faire un silo et juste parler de FGS comme si c'était une chose isolée qui n'est pas reliée au reste du corps, parce qu'il y a quand même d'autres répercussions sur la santé holistique, enfin la santé totale de la personne, quoi.
Oui.
Et comme on a mentionné, la santé mentale aussi, parce que quand on a une maladie chronique, ça peut influencer sur le moral et ça peut faire des dégâts au niveau du mental, quoi. D'où l'intérêt de groupes de soutien, par exemple. des groupes, j'en sais rien, sur WhatsApp ou quoi, pour échanger, ça serait vraiment bien.
Ouais.
Donc voilà, mais en tout cas, merci à tous. Merci, thanks to all the panelists. I'm really honored to be here and speaking to all of you. So thank you for inviting me also, Paula and all the others at the SCF. Merci.
Delphine, not only has your testimonial been very moving, but also you've come up with a lot of very practical ideas and suggestions, and this focus on the chronic aspect, I think, is not really often touched upon. So actually, I think the FGS community is really grateful to you for highlighting all of these gaps and coming up with very concrete next steps. So a massive thank you. And thank you for those kind of final words, reminding us not to view FGS in a silo as an individual disease and in a way a woman's disease. And there's linked to that. I was going to conclude on that, but this kind of fits in really well with what you have just said. There's a very important comment in the chat by Ogechukwu Aribodor, who's picking up on Dr. Kouamin's point about precision mapping. First of all, precision mapping of schistosomiasis is highly advocated, especially with respect to contextual differences. And Ogechukwu, you very rightly bring in the notion that males feel marginalized. And most recent studies show that males were usually more infected than the girls. Male genital schistosomiasis, a topic maybe for another day, but again, a really, really neglected and stigmatized condition on the same level as FGS. Ogechukwu finishes by saying also praziquantel really helped to reduce prevalence in so many parts of Nigeria. So thank you very much for this comment. I'll just turn now again to back to the Schista program. So we've got Dr. Nanyangwe Siuluta on the call. I think we've also managed to find Ruth Mwanza, community health worker with the Schista project, and also Professor Bastindui has also appeared on screen. You may see that. So again, I'd like to ask for some final thoughts from everyone at the Schista project. If you're happy to put your cameras back on. Ruth, we haven't heard from you. We would love to hear from your perspective, some of the key challenges that you've seen as a community health worker, but any kind of next steps. Where would you like to see more resources coming from? Which sort of partners do you really need support from? If Ruth can answer that, then perhaps yourself, Dr. Nanyangwe, Professor Maya, over to you. Everyone's being very shy. Oh, I think you're on mute. Sorry.
Sorry, I just thought maybe I should give Ruth a chance to talk. I don't know if she's on.
I suddenly can't see her anymore. Let me try to. Yeah, maybe she's disconnected again. Really sorry about that. We were hoping to hear from Ruth.
Okay, no, it's okay. It's fine. I can highlight some of the things that I feel. So basically, I think some of the challenges that they've been experiencing is basically, the awareness issue. Like, I think we should go all out with the awareness. Just like how, most of these programs have tried to reach like the elimination. They've been able to advertise in all sorts of ways, using all sorts of health promotion techniques, the radio, using the media, reaching out to the communities, using the healthcare workers and using the community workers themselves so that they can reach even those people that are in the, hard to reach places. And I also feel as though, we should also sort of come up with sort of like a goal target in order for us to sort of have, a certain percentage of people that we can actually detect or we can actually screen and we can actually treat in order for us to, finally, or one day at some point reach a elimination. So it would be good to sort of target those kind of partners that will be able to help, work with us in, dissemination of information, as well as, come up with a plan, sort of a global initiative, a global target that will help us, reach out to the women and be able to, like, one day achieve elimination at some point, because I think that is our aim. And another thing that we would need is the human resource. We are grossly understaffed. I think more training, is needed of healthcare workers, or even, some lay people, who can actually be able to work and help, spread the word. As I said, most elimination programs, programs that have tried to reach elimination, like HIV, have targeted, community health workers who've actually been able to sort of be trained and, with testing in the communities. And, they've been able to reach their target and, hopefully reach elimination. Yeah. So I think, as I said, multi-sectoral collaboration, we need everybody on board, and everybody has lighted the men as well. Educating the men as well, and also targeting MGS is also quite vital and quite important. Yeah. So I don't know, I think Dr. Maya stated that Ruth is online. I don't know if she would like to continue.
I hope so. I will ask someone who we think is Ruth to unmute, whether this is Ruth. Ruth, if there's any way you can signal to us if you're here. Okay, sorry, that was Amaya and not Ruth. Okay, well, we've got a few more minutes anyway. So Ruth, we will keep looking for you somewhere in the ether of the internet. In the meantime, perhaps I will go back to Dr. Bodo, Dr. Ranjuana Solo. Je me tourne vers vous, Dr. Bodo, juste pour, si vous êtes encore là, oui, tout à fait. Juste pour avoir quelques mots de conclusion, le mot de la fin. Qu'est-ce que vous souhaiteriez voir comme soutien ou comme ressources ou financement peut-être pour pouvoir continuer votre travail ou accélérer vos résultats? Ah, Delphine, I think, sorry, pardon, Dr. Bodo, Delphine nous quitte. Delphine, that's totally understandable.
I have another meeting. I'm so sorry.
Absolutely.
Thanks to everyone. I've left my details in the chat. I'd love to speak with you, Olympia and Bright Academy and all of these wonderful people. Please do get in touch. And Marianne, if you can download the chat script after Save Chat, I would love to get a copy.
Absolutely. And yeah, we're really looking forward to keeping in touch. Thank you so much.
Merci
Delphine.
à tous. Bye.
Yeah.
Merci, merci.
Take care.
Au revoir.
Bye. Au revoir. Wonderful person, an incredible advocate. Very lucky to have met her today. Dr. Bodo, pardon, je vous ai coupé. Je passe à vous pour quelques mots de la fin.
Pour conclure, je remercie toutes les équipes qui ont participé au programme de PGF dans le monde, parce que depuis, ce n'est que quelques personnes qui ont participé à la lutte contre la PGF, mais actuellement, il y a une progression pour la lutte contre la PGF. Nous sommes en train de préparer, à titre d'information, nous sommes en train de préparer une application qui pourrait nous aider à diagnostiquer la PGF. Nous sommes en attente de financement et nous allons procéder à l'essai sur terrain. Et en ce qui concerne le traitement, je vous promets que d'ici quelques temps, notre conclusion sera publiée.
Parfait. Très bien. Merci beaucoup. Et bien sûr, nous attendons tout cela avec impatience et avec beaucoup, beaucoup d'intérêt. Merci de vous être joints à nous. I'm going to try one more time. If we've got Ruth, yes. Very cheerful music.
Okay.
Okay, Ruth. Hello.
Yes.
Thank you for joining us.
I was trying to to click on my phone. I don't know what happened until I managed now. I was
worry.
listening to every conversation. Yes.
Don't worry, it's wonderful. We've made it in the end. Ruth Wanza, just to remind everyone, you're a community health worker with the Schista project. And just kind of in the last few minutes of this webinar, from your perspective, right there in the field, in the communities, what would you like to see a lot more of to make sure that FGS really gets embedded into women's health, embedded into healthcare for women?
I'd love to see that all the women are met and are all treated that are found with an FGS. Yes, as for now, we are looking at women from the age of 15 to 50 years.
Mm.
Yeah, but before I go any further, I'd love to tell you about my past study in 2018. Yeah, I worked with Buhazi study from January to August 2018. We used to look at women from the age of 18, from the age of 24 to 30. And women by that time there was a lot of Buhazia, and a lot were found with the Buhazia parasite were treated on that one. And this time we're looking at women from the age of 15 to 50 years, meaning now everybody whom we left that side who was not in the age criteria is now covered up. They're all participating in the study. And I'm glad to say that there's a lot of FGS here in Livingstone, Zambia. And we're glad that the treatment is there and people are responding well. Yes, unless if they're not in the age criteria or maybe they're pregnant, because we don't go for the women that are pregnant. But if they're menstruating, we wait for them to finish. As a community worker, I'm glad for the response they're giving us in the community. And it's a great pleasure that they're accepting our study. Everybody is participating. Yes.
That's fantastic. Thank you, Ruth. That is something we hadn't touched upon. We'd heard from Dr. Kouamin about extending the projects from the 7 in Cote d'Ivoire to the 47 that need to have these programs rolled out into. But you're right, the age bracket of the women being approached and considered for screening and treatment also needs to be broadened. So thank you. That was really important.
Thank you.
We can't wait to hear more about where this very exciting Schista project is going to go and how it's really going to support women's health in a very innovative way. So we'll definitely be watching this space. Thank you to all of you who represented this project today. And just to conclude on this incredibly inspiring webinar, I'd like to hand over to you, Professor Gyapong, bringing all this back to the ethos of today, International Women's Day. So not just focusing on acute health issues or diseases, but really looking at all of this under the umbrella of equity, possibly even human rights, or just in a broader sense, of really advocating for women's health. What might be your final words, and also what you'd like to see more of going forward?
Thank you very much, Anouk. What can I say? We've had quite a number of women on this panel, and I'm also happy to see that we have men on the panel. And usually when we are talking about equity and gender, sometimes we forget them. But I'm happy they are there, and they are going to also be able to talk about the issues of women, even as we bring them on board. I saw in the chat an issue about MGS, male genital schisto, and female genital schisto. Yes, we started championing the cause of FGS, but it's important that we also start talking about MGS so that we are seen as being equitable and being very gender sensitive. So basically, that's what I want to say. The issues about our educational curriculum, we shouldn't just talk about FGS, but include the MGS also, so that it's taken on as a holistic issue that needs to be dealt with. let me say thank you for allowing me to be on this panel. Thank you very much.
The thanks is all from us to you, Professor Gyapong, and also to all of our other panelists today, as well as everyone who's being very modest and not coming up on screen, but who worked tirelessly to bring this series of webinars together. Paula Plaza from the SCI Foundation, Anna Georgeson, Ashley, thank you to Ashley Preston, thank you so much, and Anouk Guvras, who's been really active on the chat and hopefully is on screen. I can see you, Anouk, but I don't know if everyone else can. And just all the many partners that you've all been representing and on these really wonderful and collaborative cross-cutting program, the FAST package, FIG, and just more generally, anyone who's tuned in today and has been really active on the chat as well. So many important and interesting ideas and angles on making this very neglected and niche issue something that will be hopefully a real cornerstone to advance women's health in some of the world's most deprived areas. So it's been a wonderful pleasure for me to spend this day with all of you. And we look forward to, this is only the beginning. That's very clear from what's been going on in the chat and just in general from all these ideas bouncing around. So we look forward to the next steps all together. I didn't want to highlight that Dr. Kouamin was a male as part of International Women's Day discussions, but that I agree was really wonderful. And hopefully next year or next time round, we will have many more. So on that note, again, a very big thank you. Happy International Women's Day. And all the best to everyone. And let's definitely keep in touch. If you have any more questions or you'd like to reach a panelist, please don't hesitate to reach out to myself, anyone at SCI Foundation or at the GSA, the Global Schistosomiasis Alliance, and we'll make sure that we keep those conversations rolling. But in the meantime, take care, everyone. And a very big thank you for joining us today. Thank you all.
Thank you.
Merci à tous.